Okay, let's dive into this. Welcome to today's explainer, where we're going to unpack a condition that is, without a doubt, one of the most pervasive and stealthy threats in modern medicine. We're talking about hypertension. Whether you're a clinician on the front lines or just someone who really wants to understand the mechanics of human health, this is a totally fascinating, high stakes topic that we need to decode together. We hear this phrase a lot, right? The silent killer. But think about what that actually means in practice. The true terror of hypertension lies in this massive contrast. On the outside, someone feels absolutely fine, completely normal, but inside, it is systematically dismantling the body's major organs. It's literally a ticking clock, and as medical professionals, we have to find a way to stop it before the alarm goes off. So, to get a handle on this, here's our game plan. 1. Defining the silent killer. 2. Target organ damage. 3. Diagnosis and clinical workup. 4. Lifestyle and dietary targets. And 5. Stepwise pharmacotherapy guideline. All right, Section 1. Defining the silent killer and understanding the baseline. Let's start right at the foundation. Hypertension is defined as the persistent elevation of systemic arterial blood pressure. Now, the absolutely critical word here is persistent. We aren't talking about a single random spiked reading just because your patient rushed up a flight of stairs or had a super stressful morning in traffic. We're talking about a continuous, unyielding pressure hammering against those arterial walls day in and day out. And when you look at the etiology of the disease, the breakdown is actually wild. A massive 95% of cases are primary or essential hypertension. Compare that to the tiny 5% slice that represents secondary causes. That staggering ratio pretty much dictates exactly how a patient workup needs to begin. Let's break those two categories down side by side. Primary hypertension, it has no single identifiable cause. It's a really messy, multifactorial web of genetics, age, obesity, maybe a high-salt diet, low potassium, stress, alcohol use, the whole shebang. But secondary hypertension, that's where you have specific, highly targetable culprits. Things like renal issues, endocrine disorders, or even certain medications. Finding a secondary cause is kind of the holy grail here, because it means you might actually be able to treat the root cause and cure the hypertension entirely. Moving on to Section 2. Target organ damage, or the internal devastation. Now, while this disease is usually totally asymptomatic, there is a major exception you need to be on high alert for. If a patient presents with a severe headache, dizziness, epistaxis, which is just a fancy word for nosebleed, or blurred vision, these are accelerated signs. This is when the silent killer is officially screaming. It's a huge red flag that requires your immediate action. Because if that pressure goes unchecked, the internal devastation is absolute. Just map it out across the body's infrastructure. In the central nervous system, it triggers strokes, TIAs, and vascular dementia. It forces the heart into left ventricular hypertrophy, ischemic heart disease, and eventually full-blown heart failure. It absolutely shreds the kidneys, leading to microalbuminuria and chronic kidney disease. It even attacks the eyes, causing hypertensive retinopathy, and beats up the peripheral vessels, increasing the risk of aneurysms and peripheral artery disease. It's a complete system-wide breakdown. Section 3. Diagnosis and clinical workup. Catching the killer. Obviously, catching it starts with measuring the pressure, but how it's measured matters immensely. Initial diagnosis usually relies on a clinic BP, which is an average of 2 readings taken while the patient is seated after a solid 5-minute rest. But ambulatory or home BP monitoring, that is the absolute gold standard for confirmation. Why? Because it completely filters out white coat hypertension and shows you if that elevation is truly persistent over a full 24-hour window. Once you've got a diagnosis, the baseline workup is all about hunting for that organ damage and ruling out secondary causes. So you're pulling bloods for a CBC, checking kidney function and electrolytes, especially potassium, along with glucose, a lipid profile, and TSH. You definitely need a urinalysis to check for proteinuria and an ECG to look for LVH. But here is a really crucial clinical detail. If you suspect secondary causes, like say your patient has resistant hypertension, checking the aldosterone run-in ratio and getting a renal ultrasound becomes a completely critical next step. Section 4. Lifestyle and dietary targets, the first line of defense. So what is the actual goal here? The entire strategy hinges on getting that pressure below 130/80 millimeters of mercury. This is the new 2025 target from the ACC and AHA for all patients, provided it's tolerated. And European guidelines totally agree. We have to actively drive that pressure down below the specific threshold. To hit that magic number, we start with lifestyle interventions. The foundation is the DASH diet, which means slashing sodium to less than 2 grams a day and actively boosting potassium intake. It also means committing to 150 minutes of exercise a week, dropping that BMI into the 20 to 25 range, and keeping alcohol strictly under 2 units a day. Look, I know it sounds like the generic advice of every doctor ever, but these aren't just polite suggestions. These are intensely evidence-based interventions that literally form the bedrock of all hypertension management. Which brings us to Section 5, Stepwise Pharmacotherapy Guidelines, the 4-step algorithm. If the blood pressure stays elevated, typically sitting at or above 140/90 or 130/80 if they have certain comorbidities, and those lifestyle changes just aren't cutting it, we take the fight to the disease using a really strict 4-step algorithm. Step 1 is monotherapy. You're picking an ACE inhibitor, an ARB, or a calcium channel blocker. Interestingly, CCBs are actually preferred in Black patients, while ACE inhibitors or ARBs are your immediate go-to for patients with kidney disease or diabetes. If that fails, Step 2 is combining them. Still elevated? Step 3 means adding a thiazide-like diuretic. And if they are still not at target, they've got resistant hypertension, which triggers Step 4, adding spironolactone or a beta blocker or an alpha blocker. But before we wrap this up, there is a massive clinical warning in the literature that you absolutely have to remember. Never, ever combine an ACE inhibitor with an ARB. Seriously, just don't do it. There is absolutely no added clinical benefit to stacking these two drug classes, and doing so dramatically increases the risk of severe adverse effects. It is a combination you want to avoid entirely. So we've decoded the hidden etiology, the systemic devastation, the diagnostic gold standards, and the precise stepwise treatments. The stakes for our patients literally couldn't be higher. So I'll leave you with this final thought. Knowing what you know now, how will you catch the silent killer in your next patient before the damage becomes irreversible? Keep this framework in your back pocket and stay vigilant. Thanks for joining me on this explainer, and I'll see you next time.